to Martha Butterfield, the Program Coordinator of NJCTS. Marty?
Kelly, thank you, and good evening, everyone. Our presenter for tonight is Dr. Alan Wegg, a licensed psychologist who received his ED from Rutgers University. His EDD, from Rutgers University. He is the founder and executive director of Stress and Anxiety Services of New Jersey, located in East Brunswick. He treats anxiety disorders in children, adolescents, and adults in both individual and group settings. His practice also specializes in body-focused repetitive behaviors, such as compulsive hair pulling and skin picking. Dr. Wegg is co-founder and vice president of OCD New Jersey, an affiliate of the International OCD Foundation, where he serves on their advisory board. He is certified by the Trichotillomania Learning Center, as well as the Behavior Therapy Training Institute of the International OCD Foundation. Dr. Wegg contributed a chapter entitled Storytelling and the Use of Metaphor in the Treatment of OCD to the 2008 second edition of the Social Worker's Desk Reference. Oxford University Press recently published his book, OCD Treatment Through Storytelling, A Strategy for Successful Therapy. We are delighted to have Dr. Wegg join us this evening, and I will now turn the presentation over to him.
Good evening, everybody, and thanks for joining us. So, up on my screen, and I am assuming on yours as well, is the title of this presentation and the basic specifics below it. So I'm going to move forward and start with a plug for where I'm from, Stress and Anxiety Services in New Jersey in East Brunswick. We are a group of therapists who focus on the cognitive behavioral treatment of anxiety disorders. That's our specialty, and that's pretty much most of what we do. And most of the people that we work with present with OCD, and most of them are children and adolescents. So kids with OCD really make up the bulk of all the patients that we see at our practice. I'm also going to start with a couple of plugs for some information that I think would be very important for anybody who's interested in working with OCD or is involved with OCD in any way, shape, or form to be aware of the International OCD Foundation and its website, and OCD New Jersey. For those of you who are relatively local to us, I'll just mention that we are an organization that has quarterly meetings and an annual conference and a quarterly newsletter and a website that people from anywhere really can get on our email list if you just go onto the website. And we're always looking for people who want to be involved or receive mini presentations to faculty members in schools about OCD in the classroom. Okay, so this is an outline pretty much of what we're going to be covering this evening. Epidemiology, just a little bit of background information about assessment and identification, and then really the information about the therapy itself. Number 4, focus specifically on using drawings and the concept of the war map with some visual examples of that. And then what I think a lot of people who have signed up are really interested in, the roles of the therapist, parents, schools, and other resources. This presentation would not be complete without some review of medication. I do want to mention that I'm a psychologist, not a psychiatrist. So as you're typing in questions for later this evening, I would just ask that you hold off on the medication questions because those are probably not the ones that we're going to be focusing on this evening. And then just other resources for you to look at. So let's get started with epidemiology, just some of the basics. Essentially, about a quarter of the people that present only with OCD. More than, or just about a third come with tic disorder as well, about a quarter of depressive disorder, and on you can see the examples there. And I would say to you from our own experience at Stress and Anxiety Services, that's pretty much a good representation of what it is that we see regarding comorbid disorders, probably with the exception that I think we see a little bit more ADD with the kids, especially the younger children that we work with that present with OCD. And then below that are the real typical presentation of the compulsions. There's, the washing is by far the most common, repeating behaviors, checking, and remember checking can mean the kind of thing where you're, opening up and the closet door over and over again, or it could just mean repeating questions. That's also a form of checking. Touching or tapping, counting, and then hoarding, which we see much more in adults than we typically see in children. Okay, so I'm going to move right along to assessment and identification of this disorder. And what I'm going to do is most professionals, and at this point because of the internet, pretty much anybody can go to the DSM-4R and look up 300.3 OCD. So I just wanted to pick up on a couple of basic things. So this is not the entire diagnostic description. The main idea here is that you have obsessions and compulsions in order to have OCD. The obsessions are defined as recurrent and persistent thoughts, and some examples of that would be things like, am I gay, or will I contaminate someone else by touching them and then making them sick, or maybe even have them end up dying. Impulses, which is really a concern of that I'm going to act out in some way. Will I take a knife and stab my mom because the knife is there and my mom is there? I really could. What happens if I just snap? Or will I scream out some curse word in the middle of class? Or images, and those are typically sexual or violent in content. They're just all images or impulses or thoughts, and I'm continuing to read now, that are experienced at some time during the disturbance as intrusive and inappropriate, and that cause marked anxiety and distress. So these are not thoughts or experiences internally that are congruent with the way that the person sees themselves. It feels very alien and creates great anxiety. And I want to also point out in that description that it says that at some time during the disturbance, they're experienced as intrusive and inappropriate. And why I think that is important is because sometimes when kids have been experiencing OCD internal thoughts, obsessions, for a while, they kind of convince themselves that these are appropriate and that that they're legitimate, and you have to kind of peel that away to the point that you can get them to really recognize and admit, well, I guess I don't really believe that's true. It just feels that way. And then once, of course, they have these intrusive obsessions, there is the result of the compulsion, which are repetitive behaviors, and we looked at a lot of the examples in the previous slide. A few of them here again: hand washing, ordering, checking, or mental acts, praying, counting, repeating words silently, that the person feels driven to perform in response to an obsession according to rules that must be applied rigidly. So the basic idea here is obsessions are experienced as something that happens to me, and then a compulsion is something that I decide I'm now going to do to help me feel less anxious. And one of the other notes that I wanted to make about the compulsion is that the term mental acts is referring to the idea that a child can be sitting right in front of you and experiencing obsessions and then responding with compulsions in their minds, and you don't even know that anything is going on. So it isn't always necessarily observable. All right, just some thoughts about distinguishing OCD from normal child OCD-like behaviors. Children are, for the most part, small people, and they live in a big world, and even adolescents live in a world where adults are controlling everything and make all the rules. And sometimes it's really important to feel empowered, and the way that you do that is you do some kind of ritualistic kinds of things. So there's a lot of OCD-ish kinds of things that we see all the time, especially in small children. And so I wanted to make a little note of some of the distinctions. So for instance, with timing, there's a difference between deliberating for a very long time over what prom dress I'm going to pick out and wear, a very important event, versus spending more than a half an hour every single morning looking at what shoes I'm going to wear that day to school. Another distinguishing factor is content. So, for instance, if a young boy is throwing a ball against the wall and catching it repeatedly over and over and over again, that may be something that he just finds enjoyable. He's practicing catching. He's just fooling around, and it's something that he can feel connected to. Whereas, let's say the same child was sort of stuck in the living room having to tap repeatedly the arm of a chair, which in and of itself doesn't have any real pleasure to it. He just feels the need to do it, or else something bad will happen, or he doesn't feel right, something along those lines. In terms of severity, you're looking at the difference between a child who won't eat dinner because the peas touch the mashed potatoes and I don't like my food mixed together, a kind of a very typical kid representation of an OCD-like behavior versus very, very strict and overpowering rules where everybody at the table has to chew their food a certain number of times and put down their fork every single time they're finished eating a piece of food and then pick it up again. And there's all these elaborate and intense rituals that are being dictated by the child's OCD, or else he or she's going to have a meltdown. And then the last thing there is function. That's sort of like eating on one side of my mouth because I have a toothache versus eating only on one side of my mouth, chewing my food only on one side of my mouth, because if I don't, something bad might really happen to mom. So it really is the reason why I'm engaging in a particular behavior. When talking about children and adolescents with OCD, the presentation wouldn't be complete without at least a mention about PANDAS. You can see pediatric autoimmune neuropsychiatric disorders associated with strep. It looks sort of like OCD, but there are a couple of differences. There are the OC symptoms or tic symptoms, or a combination of the two. The onset is usually with children 3 to 12, so you don't see PANDAS with adults. There was a very dramatic onset. Typically with kids, when they come to our office and they have OC symptoms, the parents will say, well, it started X number of months ago, and we noticed this, we noticed that, it began to build up, and we kind of just reassured them, or we kind of ignored it, and then it just got worse and worse. With PANDAS, typically the parents will say, my child was perfectly normal and fine 2.5 weeks ago, and all of a sudden, out of the blue, this thing has just erupted, and it's completely out of control. And of course, the onset is associated with strep infection. When people come in and they say, this is what's happened with my child, one of the questions we typically ask is, just previous to that dramatic onset, was there a strep infection of any kind? And if there was, within 2 or 3 weeks or even a month prior to that, we ask them to go have them checked out by a physician. And then the other piece is neurological soft signs are present. Typically, it's something like if they hold out their hands, you can see a small tremor that they might have. And the treatment involved with PANDAS is really very, very similar to the treatment for OCD in general. The only difference is they also get the treatment for strep infection. So they'll take antibiotics prescribed by the physician. All right, so let's talk about some school-related OCD symptoms. These are the kinds of things that teachers and school officials can look for to begin to identify the problem. I want to mention before we even look at any of these that, of course, any one of these behaviors can be explained with something else or by something else, which is why, sometimes OCD identification and assessment can be tricky. An example that's not even on this list would be, let's say every single time you ask a child a question, he or she has a very long delay before they answer. Well, is that a problem with cognitive processing? Is it a problem with a speech difficulty like stuttering? Is it just social anxiety? They're extremely shy, and so they have to kind of just review in their minds what they need to say before they say it? Or is it some kind of OCD ritualizing that's going on in their head that they have to do before they're able to talk? And the answers to those questions have to come with a series of other questions that are part of a larger assessment. But you can see here some basic things that we see, a lot of bathroom breaks so that they can go and ritualize or just to de-stress, arranging and ordering things, dry, cracked, bleeding hands, of course, from lots of washing, repetitive seeking of reassurance, which, of course, can also be asking the same kind of question using different words over and over again after the teacher has already made it clear what the answer was. And then a lot of checking, mistakes, locker, etc. The rest, I think, are pretty self-explanatory there. And really what you're looking for is a pattern that represents itself amongst several different symptoms and often amongst several different situations. All right, going back to our list. Rapport building, psych education, storytelling, and the use of the toolbox. So this is really just about the therapy itself. Now, the most common and most researched way of dealing with OCD for adults and children is a combination of cognitive behavioral therapy and, if needed, medication. And the cognitive behavioral therapy of choice is exposure therapy or exposure response prevention therapy. The little thing that I bring into the world of OCD myself is this concept of storytelling. And really what I do is I use stories as a way of explaining OCD and its treatment, because the symptoms are very bizarre. Sometimes they're very scary. They look psychotic, and people who have the symptoms, children as well, often feel really, really crazy and ashamed and really scared of their own symptoms. And this is about really sort of explaining the symptoms and also explaining the therapy, which is counterintuitive. It's very strange. So I tell a series of stories, and we don't have the time for me to tell all of them, so I'll just very briefly mention one of the main ones that I tell, which is the bee trap. And the idea there is in a bee trap, when a bee enters a bee trap, there's a darkened part of the trap that you need to go through in order to get out. And then there's a lighter part that's deeper in the trap. And so when the bee enters the trap and gets stuck in the trap, it tries to go out by looking where the light is, the lighter part that's clear. Because usually the way out of something that's an enclosure, like a hollow tree trunk or a cave, is where the light is. And so it continues to do that because it's inside a bottle or some container. It, of course, hits the plastic and it gets stuck in there. Alternatively, the way out really is to go towards the darker part of the bottle or the container, and that's where the exit actually is. That's where they came in. But they won't do that because it feels like they're going deeper into something. And so the metaphor essentially is, in order to get out of the trap, you really have to fly in what feels like the wrong direction, fly into the darkness. And with exposure therapy, what we're saying is, when something really scares you, touching something or doing something or going somewhere, the inclination is to say, well, I'm going to avoid that, or I'm going to undo that, or I'm going to do whatever makes me feel safe and in control. But what that does is, even if it makes you feel a little bit better for a short period of time, it keeps you trapped in the fear. And really the only way to free yourself from the fear is to what we call fly into the darkness, or fly towards the darkness, or in this case, move towards the very things that make you feel uncomfortable and frighten you. And therefore, you're exposing yourself to the source of your anxiety. So it's very sort of anti-regular thinking. It's not your typical linear thinking. And there's a couple of rules about exposure therapy. And for these couple of rules that I'm going to touch on with you today, I am going to actually share with you a story. And I even have some illustrations. I don't always use the illustrations when I'm actually using the storytelling in therapy. But for our purposes here, because I'm not standing in front of you, I think it'd be nice to have these visualizations. So you understand the concept of exposure therapy, flying towards the darkness, facing your fears. And let's talk about some of the rules of exposure therapy. And the first story regarding that I call the horror movie. And it goes something like this. So you and I are really good friends, and you call me up on the phone, and you say, let's go to the movies. And I'm so excited that you called me and asked me to go to the movies with you that I don't even ask you what movie we're going to. I just say, okay, fine, let's go. And we walk to the movies, and we're talking, and we're walking, and we're not paying attention at all to the actual movie theater that we're going to. I don't know what movie we're going to. We pay, we go into the lobby, and then we go and we sit down and we start watching the movie, and everything is fine. Now, in this story that I'm telling you, you love really scary horror movies, the kind that a lot of adolescents will go to. I, on the other hand, do not. And so the movie begins, and you're thrilled with it, but I all of a sudden realize the mess that I've gotten myself into, and I think to myself, I have got to get out of here, which we call an escape response, which means I run away from the thing that scares me. And so I do that. And in the lobby, I calm down a little bit. I've removed myself from my source of stress. And at that point, it may be hard to get me back into the movie theater. But let's say you know my weakness, and you say, I have seen them selling in the lobby right over there those big buckets of popcorn with extra butter. And I will buy one of those for you if you stay and watch the movie with me, because I really want to share it with you. And, well, popcorn's my weakness. And so I say yes. And I sit and I watch the movie with you. And I don't cover my eyes. You know, there I am peering over the popcorn. But I really do watch it. And it's very, very tough because it's a very scary movie. And my heart is racing. I'm breathing really fast. I'm sweating up a storm. I'm shaking. I'm nauseous. I feel faint. I'm just a mess. And at the end of the movie, you turn to me and you say, well, that was really great. And I say, not really. I was really a wreck over here. And you say to me, you know, I love that movie so much. Would you please, could you please stay with me one more time while we watch the movie a second time? And I say, I don't know that I can do that. And you say, well, you know, how about if I get you some more stuff to munch on? And so I agree. And there we are coming back to the movie, into the theater, after going out to the lobby and getting a whole bunch of other stuff. And we watch this movie. And somehow, some way, even after watching the movie 2 times in a row, you say to me, how about we watch it a 3rd time? So here we are spending an entire day at the movie theater, deep into the night, this marathon set of sitting and watching this movie. Now, a second day comes by, and you call me up and you say, how about let's get together? And I say, fine, what do you want to do? And you say, let's go to the movies. And somehow you get me to go to the movies again. And there we are watching the movie again. You've got me some more stuff to munch on. And after we watch it this first time through, we watch it yet a second time. And then there we are watching it yet a 3rd time. And so now we've gone 2 whole days watching this movie 3 times in a row. And you know, when I'm talking to the children, just to make sure that they're paying attention, I'll say things like, so how many times have I watched the movie with you so far? And so it's 6. And then another day goes by, you call me up on the phone and you say, how about let's go to the movies? And I go with you. And there we are again on yet another day, and we watch it once and twice and 3 times yet again. There's a lot of good stuff, I think, in this particular lobby. You can see all this food that they have. And it's a 4-day weekend. You call me up once again, and there it is. We're sitting again with more food, and again and again. And so over the course of 4 days, we've spent marathon days watching the same movie in the same movie theater over and over and over again. And so the question that I pose to you, the client, is, do I respond to this movie, there we are still eating and watching, do I respond to this movie the 12th time the same way that I responded to it the first time? And most kids, even really small kids, will be able to say, well, no. And I'll say, well, how was it different? And they'll say, well, it doesn't bother you so much. And I'd say, why? And they'll say, well, usually the answer is something like, you know what's coming, there's no more surprises, but more than anything else, the term, well, you just got used to it. And that's true. I get used to it. And then I teach them, some psychoeducation here, the clinical terms that we utilize to describe this process. We call it habituation. The word habit is in there. And another term that we use is desensitization. The word sensitive is in there. Now, you know, even after the 12th time, I might not enjoy the movie the way that you do. If anything, I'll be bored. But the most important part of all of this is that I will no longer have that very strong anxiety reaction that I described to you earlier. So people hear this, you know, this story about the bee trap and flying into the darkness, and they hear about the horror movie, and they understand that I have to face my fears, and if I face my fears over and over and over again, I will ultimately get over them because they won't bother me anymore. But they will then say to me, but Dr. Wigg, I'm really not interested in doing this exposure response stuff because I don't want to feel like you felt when you described going to that movie for the first time. That just feels too scary and out of control for me. So I would rather forget the whole thing. When that happens, I say, but there's yet another story that has yet another rule associated with exposure response prevention, and I call that story the swimming pool. It's a very quick story. It's nothing like the first one. Basically, the idea is you have a very, very hot summer day. You have a freezing cold, unheated, in-ground swimming pool, and you have 2 strategies for entering that pool. One is the running cannonball dive, where you throw your body over the deep end of the pool. You stick your knees into your chest. You make yourself into a big ball, and you slam your body into the frigid waters, and you scream for 30 seconds or whatever it takes, and you get used to the water, and then you can play. What's the other way of going into the pool? And usually they'll come up with the answer, which is you go over to where the stairs are, and you put in your feet, and you let them get used to it, and then you go in, and you let your knees get used to it, and then your thigh, and on like that. And, you know, the main difference here is that you have complete control over the speed on which you go in. Once you jump over the deep end, you're in the air. There's no controlling it. You're going in. Here you can slow down or speed up, and there's that sense of control. The only downside is it usually takes a lot longer. But that sense of control is very important. And so when we talk about exposure therapy, basically we're talking about facing your fears, flying towards the darkness, going towards the things that really scare you, understanding that you can go to them over and over and over again, and that will lower your fears. But you can do it in small steps, 1 step at a time. And once you kind of get over the fear at a lower level, you can then go on to the next level and next level and next level. And the art of the therapy is really coming up with these different stages, what we call a hierarchy of exposure, that people can get used to it in a way that they can feel in control of. Let's talk about just one of the main tools that we use in this toolbox, which is really just skills and ideas that we teach children about so they can better understand how to utilize exposure therapy. And one of them is what we call the fear thermometer. It's just a scale, a 1 to 10 scale, where they can indicate how scared something is making them feel. And this is really very important for a lot of reasons, because if, let's say, touching something in the office right there with me makes me feel like a 6 or a 7, most of the time children will find if they continue to touch and then touch other things and then go back and touch, let's say, a cup and touch other things and go back and touch the cup and touch other things, that if they do that for a while, even after just a few minutes, they can then say to me, well, I felt like a 7, and I guess now I feel more like a 6.5, and sometimes even more than that, 3.5 or 2.5. And that being able to communicate and articulate for themselves a real change in anxiety really reinforces that idea of habituation and desensitization. It also allows them to get a sense of their accomplishment over time with different kinds of exposures. And so we really teach them how to really be able to talk about their levels of fear. Okay, so a lot of things that we use with kids, and sometimes they're with small kids. Most of the time, a lot of these things are with the smaller children, but we use it with adolescents as well, and even adults, actually, a good amount of the time. The thing about children, especially younger kids, is this whole idea of having this psychiatric disorder and challenging your fears can get very complicated when it's all inside of your head. So what we're trying to do is concretize it, make it more concrete, take it out of their head and sort of put it in the real world so they can have a sense of grappling with it and dealing with it in a more real, physical way. And one of the ways we do that is by asking the child to give their OCD a name and to give their OCD a look. What does your OCD look like? It could be a boy, a girl, a man, a woman, an animal, a thing, a monster, an alien, whatever you want. But this way, it gives them a sense of separation from their OCD and allows them to sit back and say, okay, you're the OCD, and I'm me, and I'm going to fight you because you're not treating me very well because you scare me all the time. Typically, we talk about the OCD as being sort of the bully. It also changes the dynamics of the relationship between the child and everybody else in their lives. So now, rather than family, for instance, fighting with the child about doing X, Y, and Z because their OCD is getting in the way, you're not getting ready fast enough, or you're engaging in all these things and we need to move on, that sort of thing, now it becomes mom and dad and child and therapist and teacher and whoever all against the OCD. And so the kid gets taken out of that situation that often makes them feel really bad about themselves, depressed, frustrated, and has some really, and can result in some very negative self-esteem issues. So let's talk about the drawings for just a couple of minutes. This is Mr. Pushy. This was a 9-year-old boy. And the reason I chose Mr. Pushy, I'm not going to get into a lot of the details about what this picture really means, but I chose him because this kid was really into Transformers. And so what he did is he has a sort of a humanoid figure that's Mr. Pushy, and then he has an animal figure that's also Mr. Pushy, and that's what he would utilize. This is a girl, a 12-year-old girl, who named her anxiety a Scooch. And here's Scooch saying, you do what I say. And actually, this was a body-focused repetitive behavior. This is a girl that did some picking, but I thought that she captured this really well when she would say, here you see Scooch saying, you better pick or else, and I blocked out the girl's name, and she goes, no, I won't listen to you. I can imagine you big or small, and I can get rid of you. You go away, Scooch. So here we have them draw pictures where they're actually engaging in challenging back this bully, this OCD. Bruise is another name for sort of an OCD that's kind of like Bruce, but he called him like Bruise because he's a bruiser. And here also is this idea of you either from right to left. On the right side, Bruise is saying, go check in the closet. And this girl is saying, shut up, you're not real. Let me say it's okay to even, say nasty things to your OCD because they're nasty to you. And kids love that because usually they have to be very respectful to everybody. And so they get a chance to act out a little bit within this context and within limits and, of course, within what parents feel comfortable with. And this next slide shows the same kind of thing. Go wash your hands, and she says, no, I won't listen to you. But what I wanted to point out here is that we also encourage kids when they make these pictures to make themselves larger than the OCD so they feel more empowered and strong, and the OCD does not feel so big and scary.
Dr. Wegg, could you try and speak up just a little bit?
I will do that. Thanks for letting me know. So a moment on the war map. This is a way, this comes from Fred March's work, and it really is a way for the child to organize the whole experience of fighting against the OCD. So this is a little boy named Tim. I think Tim was 11 or 12. And this is Tim's land, which is basically his life, his entire experience. And you could see on the bottom, he's identified OC Dragon, which is the name of his OCD. He actually made a model of a dragon, and that became the name of his OCD. And he had brought in a shining knight on a horse, which was representative of him. So his goal is to slay the dragon. And here the idea is that on the left-hand side, where you see the crisscross in orange, that this is where OCD really wreaks havoc. When he has these bad thoughts, or when he worries about having raw egg on his hands whenever he's in the kitchen, or going to the bathroom at night by himself, those are the real tough times for Tim. On the right-hand side, in the blue crisscross, is Tim's territory. This is where Tim feels really in control of his life. When he brushes his teeth, when he puts on his socks, when he's sitting on the piano bench or chair at dinner, those are examples of where he feels, I'm pretty much in control. And then there's no man's land. So there's a few things written in there under all those crisscrosses where sometimes Tim feels a little more in control and sometimes OC Dragon's really in control. And so the idea here is that we sort of attack each of those asterisks one at a time as if we're attacking cities. And the goal is to sort of push OCD off of Tim's land. So it's a very nice physical representation of challenging the OCD and gaining back one's life and control. Let's talk about these roles. Okay. So there's a lot of information here. I want to spend some time looking at this. This is for parents, but of course teachers, although a little less so because they have a lot less time on one-on-one with kids, and there's a lot of other things going on in the classroom. When you can begin to identify any OCD symptoms, it's very important to label the problem as OCD. And within the context of the classroom, sometimes we set up little cues, like the teacher will touch his or her nose as a signal to the child that I think this is your OCD, so that we're not talking about this in front of all the other kids. You label the problem as OCD. So we're just saying this is what's going on. This is why I think you're asking this question for the 5th time. We empathize, basically reflecting what we think your child is feeling. I understand that it feels really scary to think that maybe you got the wrong information. You feel like you have to ask yet again. However, this is really about the OCD. But you're letting the child know that you're not just being dismissive. And you want to let them know that you really get that this is very, very hard for them. And really, it's important for you to remember that, you know, when you're asking them not to ask the question for the 5th time, or that it's okay to go on to the next question in homework, or that it's okay to touch this thing, or just to get up and move without engaging in some ritual, that's like asking you to jump off a building and feel that it's going to be okay. You'll land into the firefighter's net down there. It's a very, very scary feeling, and you want to empathize with the child and let them know. Also because then they're going to trust you a little bit more with the next piece, which is reminding them about doing the therapy, which we can call show and tell with the younger kids, showing the OCD who's boss by just not doing what he or she is telling you to do, and then telling the OCD to go jump in a lake or worse. So you're fighting back the OCD by your behavior, by basically doing the opposite of what OCD is telling you to do, and then telling the OCD, I'm not going to listen to you, either mentally or actually verbally if you have the opportunity to do that. And then once you've done that, refocus on whatever the preferred activity is, and ultimately reinforcing your child's efforts, even if he or she has struggled significantly with this. I'm always encouraging parents to look, and teachers to look for any change in the focus of their work. So the slightest little thing can be a plus. So if a chair is contaminated, even something like touching the air around the chair, if that's scary for them, is where they're at. That's where they have to start. The basic rules of encouraging, I'm going down the left column now, gentle but firm reminders, emotional support, and positive reinforcement about fighting, as opposed to discouraging, punishing, blaming, and nagging. On the other hand, you do want to set limits and boundaries, and what I mean by that is a lot of times families come in, and OCD has completely taken over the household, and parents have to go through this elaborate set of rituals with the child. I have to say, I love you 6 times whenever they say I love you during good night, and if I don't do this, they have a meltdown, and we're serving them in another room because they can't eat in the kitchen anymore, and now they're sleeping in the family room, and they don't sleep in their room anymore, and no one is allowed to use this bathroom, and there's all these rules, et cetera, that really kind of suck in the rest of the family members. And typically what we say is you really want to remove the parents from accommodating the OCD, but you can't do that all at once. So one of the things we usually say is no new accommodations. There you see it at the bottom of the page. At this point, nothing new that the OCD has not demanded before will not be followed through. And then we very slowly begin to cut back from what the parents are doing with the child's knowledge in advance, and if they could be even part of that process of deciding how are the parents or teachers going to start to cut back, that's even better. But if they don't, then the bottom line is that we're going to do it regardless, because except for when we're concerned about safety, the rules are no one is going to force you to challenge the OCD or stop a ritual. However, you are not in a position to force us to engage in certain kind of behaviors just because your OCD is telling you that we have to do it a certain way. And that's really where the behavioral boundaries are. Again, the only exception is when we're really concerned about safety of the child or somebody else. One of the other things I also want to mention here is that there should be consequences for non-OCD misbehavior. So if you don't do what the OCD tells you to do and the child starts cursing or misbehaving in other ways, breaking furniture, whatever it is, you don't say, well, they're just behaving like that because of their OCD. You can't do that. You have to respond to the child in the way that you would if they were misbehaving for other reasons. And, of course, one of the other parts of therapy is teaching them how to deal with their frustration more effectively, how to manage their anger a little more effectively. But you cannot allow the kind of behavior that you wouldn't normally allow to take place in your family just because you're beginning to fight back with the OCD. One of the hallmarks on the bottom there is also no reassuring. What do parents typically do? It's okay, honey. Don't worry about it. It's really nothing. It's going to be okay. Look, I'm touching it. All that kind of stuff really goes nowhere because that's a rational, normal, linear way of trying to address someone's fear. It goes nowhere. And the truth of the matter is family members usually come in already knowing that it goes nowhere because they've been trying it for weeks, months, or even years and have watched the OCD get progressively worse. And the reason is because you're flying into the light. It may make them feel better that particular time, but then ultimately it strengthens the OCD problem itself. Therapist role, just a few words about this. I explain to people right away that this is cognitive behavioral therapy, so this is not the kind of therapy where people sit down, lie down on the couch, and just talk about their week or talk about their dreams or even talk about early child life experiences. This is really about just focusing in on the problem at hand, and I function as a coach and as an educator. Some of the rules are I will never ask you to do something that I myself wouldn't do, and I will never make you do something that you refuse to do except when safety is involved. Also, I determine what is OCD, as does your parents, rather than you do, because a lot of times they'll say, well, it's not OCD, it's just because this is what I want, when clearly it's not true. Now, there may be times that a child asks something or wants something or is acting out in a particular way, and it does have nothing to do with OCD, and you've got to kind of do your best at kind of guessing whether or not it is or not. The main thing here is that the adult has the last say, because you don't want to get involved in these arguments back and forth. What I do is I focus on involving the child in creating that hierarchy by always saying, if you can't do this, whatever it is we're talking about trying to do, what can you do? So again, looking at that chair that's contaminated. Well, where is it most contaminated? Typically where a person sits down or where they lean back on their chair with their back, where the body contact is. So let's say you can't touch there. What about the arms of the chair? Feels too contaminated. What about the legs of the chair? Nobody really touches that. Well, it's really kind of connected to the chair. Well, what about the floor that the chair is sitting on? Well, it's still kind of directly connected. So let's start with just touching the air around the chair. We just start with wherever the child is at. What we don't do is we don't say, okay, that's too hard for you, so we're not going to do anything. There's always something that the child can do to begin to address and approach his or her fears, even if it's just sticking the very, very tip of their toes into that ice-cold pool. Collaborative effort is something I've talked about already several times, this idea of having the child involved, using a humor. And we've talked a lot about anthropomorphizing the OCD, giving it a personality, a different sense of self, and taking an us against it stance. School roles is basically to be informed and educated. And I mentioned OCD New Jersey, and there may be other affiliates around the country that go in and make presentations to faculty members about OCD, learning about it and its possible side effects, making appropriate referrals clearly to the school counselor, child study team to begin with, and then to persons who are trained in this kind of work on the outside, and implementing school-based interventions and appropriate short-term accommodations. And I emphasize short-term because accommodations, remember, are flying into the light. But sometimes we want to get that kid in school at least, and so we may accommodate them to a certain degree, but then right away we're working on pulling back from those accommodations one small step at a time. And then there's just the IDEA and the 504 plan that you can do, whether it's the different methodologies of implementing these interventions. I'm not going to spend any time on that. Other roles are support groups and organization affiliation. I've mentioned a few of those, and I have some more at the end of this. Readings, and then videos. The International OCD Foundation and OCD New Jersey, you've gotten the websites previously, they have DVDs of all kinds of stuff about OCD. And there's plenty of internet sites. Of course, like with anything on the internet, you have to look at the sources, and that's why I've given you a couple of the ones up front that I think are very reputable. Talk a little bit about medication. The first line of medication tends to be anafranil, which is its own thing, and then all the SSRI, selective serotonin reuptake inhibitors. And there's a list of the medications. The first name is the brand name, and then there's the generic name in parentheses. And those are the dosages typically for kids. And while there's been some controversy about something like Prozac for kids because some of them actually responded with being suicidal or being very depressed, there were very, very few cases. And you have to kind of think about that the way you think about, peanut allergies or strawberry allergies, which can be very, very dangerous. And typically what psychiatrists will do is they'll prescribe very, very small dosages just to begin to see how kids will react. And then if those medications don't work that well, there'll be these augmenting medications. And there's a whole list of different ones, way more than I've listed right here. The only thing that I want to mention is about these other medications, these benzodiazepines like Klonopin, Ativan, and Xanax, which are anti-anxiety medications, and you think, well, that should be a really good thing to do here. And sometimes it actually does help, but the problem with those is that you can build tolerance, you can get addicted to it psychologically or actually physiologically, and then you have to work on essentially a weaning off of these medications. And more than all the other medications listed above, these benzodiazepines actually get in the way of the exposure response therapy because it numbs the anxiety, and you need to feel that anxiety to experience habituation and desensitization. Again, please no questions about the medication because this is really not the place for it, and I'm not a physician. Some other resources. There is, again, the International OCD Foundation, OCD New Jersey, and then New Jersey Association of Cognitive Behavioral Therapists. But for those of you who are out of the area, well, there's, my stress and anxiety services and our website. Some national organizations, ADAA is listed there, and ABCT, with all their contact information, which you can always look at a later time. Some readings. Freeing Your Child is a really good one for parents. OCD in Children and Adolescents is a really good one for therapists. Blink, Blink, Clop, Clop, Up and Down the Worry Hill. Those are two good really good ones for children themselves. OCD Treatment Through Storytelling is my little plug of what I think is a really nifty little book. There's about 60 stories, each one really focusing on a particular aspect of the experience of OCD and its therapy. And then I just wanted to add this one specifically for this presentation, Students with OCD by Gail Adams, A Handbook for School Personnel. It's a really, I haven't read the book myself, but I've seen her handouts that the book is based on, and they're just wonderful, very specific, clear ways of identifying aspects of OCD in the classroom and how a school can respond, the teacher in the classroom, the child study team, the school as a whole. So I would highly recommend that book. And that's about all the time that I think that I have for everybody. So thank you all very much, and I'll hand it over to the people who are running the show.
Well, thank you, Dr. Weg. That was excellent, and we are inundated with questions, I have to tell you. So I think I'm going to launch right into those, and I'm going to start with a question having to do about genetic prevalence in families. So the question is, what, if any, is there a genetic prevalence in families? And second part, are girls more susceptible than boys?
Okay, well, I'll answer the second part first. Everything that I've seen and that I know says that there's no gender preference for this disorder. We see it equally in boys and girls.
Okay.
There may be a slight change in terms of at a younger age, boys get it, at an older age, girls get it, but that might be a study or two, but it's not really standing out for me to suggest that that's a strong preference, a strong prevalence in the research. In terms of the genetic piece, basically we have not found or identified a specific gene that's responsible for this, but it does seem to run in families. Of course, there's always the question of the nature-nurture controversy, but there is a sense that there's probably some genetic predisposition that's then expressed biologically through the presentation of the disorder. So we often ask about whether there is OCD in the family history as a way of part of the assessment phase.
Okay, fair enough. Thanks. The storytelling therapy, it would seem to me that it's most effective, obviously, when the child is receptive. So what is the right age to begin, and is there an age when it loses effectiveness? Like, does the teenager just get too cool for this stuff? So
Okay.
How does that work?
That's a big question. First of all, we've seen children in our practice as young as 4. As with a lot of therapies that aren't play therapies, and cognitive behavioral therapies of any kind, the younger the child, typically the more involved the parents are. So we're really doing sometimes a lot of behavioral management, a lot of teaching of the parents how to respond to the child. And the older the child gets, the more they become actually involved in this. But naming the OCD and drawing those pictures, 4 or 5-year-olds are really great with stuff like that. They really eat it up. The whole idea of anthropomorphizing the OCD is something that they're very comfortable with because their fantasy life is just so at their fingertips anyway.
So that picture, those kind of the kids, there was one girl, I think, in a polka dot dress or something like that. That was done by a 5-year-old?
No, not the ones that I showed you.
Okay.
The one with Bruce, I think the one with Bruce was pretty young, maybe a 6 or 7.
Okay.
But we have had, even if it's a stick figure, it really doesn't make a difference. It's about making it separate from you. And they really do seem to get that concept. In terms of the adolescents, that's always a challenge. Most of the time, and one of the reasons I love working with OCD is that people come in and they're really motivated because they're miserable. They're really unhappy, and that makes my job always a lot easier. But when you do have parents who drag in their kids, first of all, what I do is I ask the parents just to say to the child, to the adolescent, they're coming in to interview me. They're just coming in to check me out. And I spend most of that time just trying to engage them. And essentially what I do is I say, well, this is what's going on. And typically the parents are very much involved in the OCD at that point. They're doing a lot of accommodations. And what I say to the adolescent is I go through this, the stories or the concepts, and I say we're going to really need to work on having your parents pull back from this stuff because it isn't fair to them. This is not their illness. This is yours. And if you don't want to work on it, that's your choice. But that doesn't mean that they have to do all this work to accommodate something that you don't want to take responsibility to work on. And so I would invite you to come and join us and be part of this process. But you need to know that if you don't join us, then I'm going to meet with your parents independently of you, and we're going to decide together without your input what changes they're going to make, and then they're going to cut home and they're just going to do it. And so I do really implore you to be part of this process so you can let us know what you think is going to be a little bit easier for you, but if you don't want to do it, I want you to understand that's what's going to end up happening. That's for the real oppositional kid.
Mm-hmm. Does
and
that
that's
work?
really the ultimate. I mean, I try very hard to engage them. I don't like, it sounds very threatening, but it's really the truth. If they don't want to be a part of this, I really don't force the parents to control. I don't advise the parents to try to control their child's behavior, but I really do focus on having them extricate themselves from their role of being, sort of this proxy person who has an extended form of the OCD. They get caught in the web.
Okay, thank you. In your opinion, does there seem to be an increase in OCD and anxiety with early elementary age students?
You mean
or is
when
it just being noticed and diagnosed more, or is it really more prevalent?
It's always difficult to say whether it's something that's just noticed more because you have someone who's living outside of the family, another adult, who's really seeing the child for the first time on a regular basis, and also that there's a whole lot more social and academic demands that didn't exist previously. We typically see bursts, early childhood entering grammar school, but also early adolescence, which could be in part due to hormonal changes, and then young adults, essentially when they go to college and all of a sudden there's a lot of independence and they're not living in their homes, and all of a sudden all the safety nets and all the controls and all the accommodations that the parents have put into place no longer exist, and they're not able to function as well with the, with the normal demands of an adolescent's life. Very rarely, every now and then, I have seen people in their 30s or 40s who had never seemed to have any OCD and all of a sudden seem to develop some symptoms, but that's very rare. Typically, people have developed it or at least see early signs of it in childhood.
Okay. Many of the behaviors that you described, and I want to ask this question because we are the Tourette organization, the question is about the behaviors you described sound a lot like tics. So would you talk a little bit about what the OCD-Tourette connection is?
That's, again, another tough one. In terms of, the genetics of it and the physiology of it, I'm going to put that aside for now because a lot of that is really not that clear, at least not to me. But I would say to you that there is a continuum. It's very clear that certain kinds of things like, an eye blink that with a jerk or a barking sound or something like that, that looks very automatic, out of control, the way that a cough would be, et cetera, is very Tourette's-like, whereas something that's much more complicated, like needing to, repeat standing up and sitting down 7 times before I can leave the room, is clearly much more OCD. But there is this blur because typically when we talk about OCD, we say, well, the child is doing this thing because they're afraid something really bad will happen if they don't do it. Whereas with Tourette's, it's more like scratching an itch, that they just have to do it because they feel a very strong urge to do it, and it just provides a certain level of relief to do it. But then Dr. Charles Mansueto, who's down in the Washington, D.C. area, and his group have developed this concept of what's called Tourettic OCD, which is OCD where the child says, I have to tap this chair a certain number of times. I can't even tell you how many times. I just need to do it a number of times until I feel okay. So it has that same kind of relief feel to it that you see with Tourette's, but it's more OCD in the kind of behavior that it is. So that's one example of how the two blur together sometimes. Another example is sometimes these sort of automatic jerky behaviors become so long and complicated that it's hard to believe that they're just Tourette's. So for instance, this may sound funny, but it's really very sad and tragic. But we have a child that we're seeing right now that whenever he gets a very strong urge, he actually will moon his pants. He'll drop his pants. This is a 14-year-old boy who will drop his pants and his drawers, and he feels the need to do this. And then afterwards feels incredibly embarrassed and feels is incredibly apologetic. Now, that's a complex set of behaviors to turn around, to face your body a certain way, to then undo your pants and to pull them down, as opposed to just an eye blink. Is that Tourette's or OCD? Sometimes I myself am not really sure. So it's a very good question, and one that I think that sometimes we can't always answer very, very clearly.
Wow. Okay. Thank you. You took a good shot at it, though. Thank you. Would you speak a little bit about mind tics? So that's mind, M-I-N-D, tics, and the difference between what would be considered a mind tic and an OCD intrusive thought. The point in the question is that mind tics, you would, such as in Tourette, you would, be told to ignore or use distraction or something. But intrusive thoughts, you're using exposure and response therapy. So can you talk about those distinctions there?
Well, again, it isn't quite that clear in terms of the OCD. We don't always necessarily do exposure for certain kinds of especially mental intrusive thoughts. Most of the time we do. So you'll think the thing on purpose and, in fact, think it even worse. And sometimes what we'll do is we'll have the person, the child, if they're old enough, write out a story of the very thing that they're afraid of. And it's very hard to do. And we do it like going into the swimming pool one step at a time. So, for instance, the fear is I'm going to take a knife and maybe I'll take a knife and kill my mother with it. And so we start entering the pool by just saying, knife, mom, and they just repeat knife, mom, until they can do that without feeling strong anxiety. And then you start saying, I might take a knife and kill mom, and then go to the idea of, how I would do it and what would end up happening and the blood and the gore. And, it's really about trying to have, where the OCD has no place else to go to scare the child because they've already done it to themselves. They've out-OCD'd the OCD. With mind tics, where you're just getting these intrusive thoughts that repeat or go over and, well, that's basically it. That they just basically repeat or they just keep changing. At a certain point, you can't run after those. You can't run after all those different thoughts because you never really catch them. It's like chasing after a butterfly. And so ultimately we end up saying, well, just sort of make it noise in the background. One of the stories I tell, again, is the idea of visiting a friend of mine who lived, and there was a train that used to pass in the backyard, and the windows were open, we were having dinner, and my friend and his family didn't even notice the train. They didn't even hear it because that train passes by all the time, and they've learned to tune it out. And we teach people that you can learn to do that with the OCD, even though it's making lots of noise. You can learn to kind of just let it be, and we call that acceptance and commitment therapy, which is a whole other thing that we did not get into today because of time. Again, what you're describing are things that sometimes have very, very subtle differences, and that there's a continuum with no clear demarcation as to where the Tourette's ends and something that's OCD finishes, begins. But sometimes the treatment is very, very similar because there is OCD treatment of, okay, well, it's okay to just sort of let it be there and notice it and then just move on and distract yourself. That's not something that's completely out of the picture.
Okay. You said in that answer that, exposure and response therapy isn't always the answer. And we had a question that it pertains to a young adult whose OCD rituals have become so interfering that he can't drive anymore, particularly that he has this urge to go into the other lane. So if exposure response therapy would seem to me wouldn't be the appropriate therapy for him given that he's in a vehicle, what other type of intervention could be successful in that kind of a situation?
Well, first of all, I would suggest that there are some possibilities in terms of that. One is imagery therapy, where you're basically doing exposure therapy in imagination. Another is practicing with, I'm blanking on the word, video games. Where you have I can't think of that word, but a representation of the real world that's done electronically and visually. They have in amusement parks and stuff like that. You go into this thing and it feels like you're actually driving. The alternate, another way of doing that is to have him practice driving in a parking lot, imagining that he's going in a different direction, but that he stays and keeps the car going in the direction that he really wants it to, or even down a quiet side street, to show himself that he could think about going in making a left or right, but that ultimately he really does have control over the car, and then moving up from there to busier and busier streets. So I think there is a way around that particular one. But ultimately, the alternative ways that we deal with are sometimes residual OCD. In other words, the person has gone successfully through treatment, but then it's just some little things that the OCD is still kind of hanging out with the person, and we haven't been able to really completely eliminate every last bit of it, because typically we don't. And that's about sort of recognizing it and accepting it as the, another story that I utilize is like the fly in the room. Rather than running around trying to kill it, you just kind of sit back and you read your book, and every now and then it may buzz past you, but you let go of the concept that I have to destroy the fly, I have to kill the fly. And this way, rather than running around the room and not reading and breaking everything that's glass with your rolled up newspaper as you're trying furiously to kill your fly, you can sit back and you can read your newspaper, so you're being productive, everything in the room is fine, and every now and then the fly goes by, big deal.
Okay. All right. Is it common for someone with OCD to involve others in their ritual? And the little caveat that was mentioned here, that this child has the mom repeating phrases, often in increments of 15 times. So could you talk about that a little bit?
Well, the answer to your question is yes, almost all the time. And we talked about it several times during my presentation this evening. It's like, we liken it to a drug and alcohol problem, substance abuse problems, where the whole family gets sort of wrapped up in, lying to the boss because, saying to the boss that the person's sick when they're hungover, or covering for them, or cleaning up after them. And so the whole family, sort of rallies around and protects the person with the drug abuse. Here, the same thing is done. Everybody rallies around trying to protect the child from feeling uncomfortable. And typically, when you feed the OCD, it gets stronger, it gets bigger, it demands more. Never give the OCD what it wants, because even though it'll quiet down for just a few minutes, for a short while, it'll come back bigger and stronger. That's what the whole concept of exposure therapy is. And so, but at the same time, like I said previously, I wouldn't have this woman go back and say, okay, I'm not answering you anymore, but rather I'm only going to answer 13 times rather than 15 times. Or I'm going to answer 14 times, and then I'm going to wait an extra 30 seconds before I say the 15th time. That
so just keep eating out of it then.
And then cutting back from there. And that has to be, usually that's where we start with the therapy, because we really want to extricate those parents.
Okay. How can exposure therapy be implemented in a session if the child doesn't present symptoms during the session?
A lot of times that doesn't happen. What we do during the therapy session is we plan out what we're going to be doing, what they're going to be doing outside of the session. And if the parents are there, then they're part of that. They basically make an agreement. We're very specific, how many times a day you're going to practice, what time's that going to be, what are you going to shoot for doing, how are you going to be using your fear thermometer, how are you going to record the information, and let's come back next week and see how things went. And so the exposure therapy, we prefer it if it can happen in the office, and most of the time there's a way for that to happen. Let's say there's something contaminated in the home. We'll have the parent put it in a couple of plastic bags and bring it into the office, as an example. But sometimes you just can't. And then we just sort of lay it out in terms of what the rules are and how everything works and how to think about your relationship with the OCD, the whole war map, drawing and naming the OCD, reviewing the concepts of desensitization, and habituation, teaching the parents how to be a good coach, support, empathize, but then, direct towards having the child challenge the OCD, everything that we talked about this evening. And then they come back and they report, A, it went well, and we move forward from there. B, it didn't go well, and we talk about why it didn't go well. Or C, we didn't do it, and then we have to look at, well, what got in the way of you doing it? And I never accept, well, we'll just try harder next week. I usually say we have to do something different to try to make it more likely that it's actually going to happen next time.
Okay. We have run over. I'm going to do one more question, and then I think we're going to wrap it up for tonight. For an adolescent with OCD, and this adolescent would become desensitized to a particular obsession compulsion. Is it likely, or how frequently would you say that a different obsession compulsion will take its place?
Okay. Before I answer, I just want to, in case people drop out early because they hear the last question, I wanted to thank everybody who's still on the line for joining us this evening and for letting me experience this. This is my very first webinar, so I hope that everybody got something out of it. I sure did. It's a very different kind of experience. I've been doing presentations for 20 years, but this is a very different kind of experience. And I appreciate the guidance that I got from Marty and from Kelly in this. But to answer the question, very typically you do see a replacement. And so I know the more psychodynamic therapists will say, well, then you're not really treating the problem because the problem's still there. And I look at it in a very different way. The way that I see it is OCD sticks to whatever is available. And so the dynamic of what the OCD is, the concept of focusing on some sense of uncertainty or lack of control and then putting ideas in the person's head that something bad is going to happen, that's always there. It can attach itself to virtually anything. And so basically what we're doing is we're teaching the child, the adolescent, the parent, how to think about this, how to respond to this. And so regardless of how the OCD manifests itself, the person now knows how to respond. And typically what will end up happening is over time, as the person keeps beating down the OCD for different representations, the intensity of the OCD tends to be less. The length of how long it sticks with whatever it's trying to challenge the person with becomes shorter, and the whole thing becomes a little more benign because you're wearing out the OCD essentially to keep up with the concept of anthropomorphication. It's like a bully that's sort of giving up on bullying this particular kid because this kid is no longer responding to the bully in the way that he wants him to. And so he tends to not pick on him so much. And that really is the dynamic. But the answer to the question is yes. Very typically, there are other symptoms that may emerge.
Mm-hmm. But the idea then is that you learn the strategies in this process, and they become the tools by which.
Right. It doesn't make a difference what form the OCD takes in terms of the content. The dynamics of how it presents itself is always the same. I'm going to make you scared that something which you know at some level is unreasonable will happen, but I'll make you so scared that you'll get confused and think maybe it really is possible, and then I'll have you do some strange thing in order to prevent that from happening or to help you feel safe. But really, it's just the thing that I need to be fed in order to continue to control you.
Mm-hmm.
And that goes for just about anything you can think of that's OCD.
All right. Well, Dr. Wegg, thank you. A lot of great information. We've had a lot of people stay on to the end, and we're delighted to have you. So thank you very much for your presentation tonight.
You're very welcome. Thank you all very much again. Have a good evening.
Thank you all for joining our webinar on OCD in Children and Adolescents, Guidelines for Parents and Educators. There is an exit survey which we need everyone attending to fill out. The discussion board is now open and available for the next 7 days on the NJCTS website for additional questions that were not covered in tonight's presentation. That website is www.njcts.org. Also, an archived recording of tonight's webinar will be posted to the site shortly. Our next presentation on sleep disorders will be presented by Dr. Lawrence Brown and is scheduled for March 28, 2012. This ends tonight's webinar. Thank you, Dr. Wegg, for your presentation, and thank you, everyone, for attending.